Good evening, everyone. My name is Justin. I'm the chair for the Resident Fellow and Student Sections Communications Committee. And on behalf of the SIR-RFS, I would like to welcome everyone to tonight's informative session on the IR Residency Program Directors Panel, brought to you by the Medical Students Council. Before I start, I would like to remind everyone that this session will be recorded and will be made available on YouTube at a later time. Also, if you have any questions during the session, please type them into the questions box or wait till the end of the session and we will cover them. So without further ado, I would like to turn your attention to the Medical Students Council for this session. You can start.
Okay. Actually, Justin, I'm missing the window, I'm afraid, for the webinar.
Oh, okay, let me change it back to you.
Oh, no, I don't want to, sorry, I don't want to share my screen. I just can't see the window anymore.
No problem. And we wanted Wynn to be the presenter first, right?
Correct.
Okay. So Wynn, go ahead and click yes, and then we'll start the session here.
Oh, perfect. Thank you. All right. All right, good evening, everyone. We're going to get started. Thank you for joining us, and welcome to the Program Directors Panel hosted by the SIR-MSC. I'm Santa Herwald.
And I'm Wenhui Zhao.
And we're going to be the co-moderators of tonight's panel.
We're very grateful to have 4 program director panelists for agreeing to take time out of their busy schedule to share the insight and advice for the residency application process. We have an exciting program tonight and really look forward to learning from each one of our panelists. Let's see. So before we dive into the panelist discussion, just going to briefly review the agenda for tonight. In part 1, we'll have a brief introduction of the IR residency structure and highlight some of the new data from the 2018 charting outcomes and program director survey. In part 2, we'll have a brief introduction with the panelists and then spend the majority of the webinar learning from their discussion of the residency application process, focusing on how to prepare a competitive application. In the end, we'll have a Q&A session from the audience. So currently there are 3 pathways to the IR training: the integrated IR residency, the independent, and the ESIR pathways. So many of you may have heard about these before, but just to keep everyone on the same page, we'll give a brief introduction. There are currently 78 integrated IR programs available for 4th-year medical students entering this year match. This is a 5-year program. The curriculum allowed 3 IR rotations in the diagnostic residency training, plus the last 2 years of dedicated IR training. The other 2 pathways are advanced positions, only available for radiology residents who have chosen to specialize in IR training during their IR residency. So the independent pathway are structured kind of similar to the traditional DR residency, with the additional 2 years of dedicated IR training. So the total years of training is 7 years. In the ESIR pathway, it requires DR resident to complete 12 IR rotations, 1 ICU rotation, and at least 500 IR procedures. So the benefit of these additional requirements is that they allow advanced placement into the 2nd year of IR residency, effectively shortening the total years of training to 6 years instead of 7 years compared to the independent residency. So given the main goal of this webinar is learning how to become a competitive applicant, for the next couple of slides, we'll have a brief overview of some recent data from the 2018 match. So for the 2018 cycle, there are 253 applicants for 136 positions. Strikingly, the match rate for IR is only 58%. So almost half of the applicants were unmatched. So to appreciate the competitiveness of IR, we could compare the match rate to other highly competitive residencies, such as dermatology, plastic surgery, neurosurgery, and diagnostic radiology. So from the applicant side, how many program is needed in order to match? So to the right here, this is a graph showing that one need to rank at least 10 programs for a 90% chance of matching. So based on these statistics alone, IR has become one of the most competitive residency. So who is considered to be a competitive applicants? Here are just some data from the 2018 charting outcomes, looking at some of the hard objective data points. So for those who match, the average Step 1 score is 246. The mean number of abstracts, presentations, and publication is 8.4. About a third of the match applicants are AOA members. And this is one category that really produced the biggest difference between the match and the unmatched applicants. Also, a significant number of the match applicants, about 21% of them, have either a PhD or other advanced degree. So these four categories looks very similar to other highly competitive specialties, such as dermatology and neurosurgery. And the program director survey was also released recently. Here are top 10 factors that program director cited for selecting applicants for either interview or for ranking. Overall, a lot of these factors are consistent with the charting outcome data. In addition, there are other data points such as letter recommendation, leadership quality, and commitment to IR. One potential limitation of this data is that there's a relatively low response rate, only 26%, so this might not be fully reflective. And we're hoping that some of these objective data will provide some discussion points for tonight, and we're hoping to learn more from our panelists about the selection process. So thank you for your attention. I will ask my colleague, Sana, to start the discussion with our panelists.
Absolutely. So, one second, I'm just going to change my slides here. All right. So the next part of our discussion for the webinar tonight is going to be the introduction of the panelists. Can you all see my screen okay? Oh.
Yes, we can see your screen.
Perfect. So what I'd like to ask is for each of the panelists to briefly tell us your name, the name of the program for which you're the program director, and if you could tell us one thing that surprised you when you first became the program director.
Hi, everyone. This is Aaron Fischman. I'm the PD at Mount Sinai in New York City of both the integrated and independent residencies, as well as the fellowship currently. The biggest thing that surprised me, and I don't know if this is exactly what you're looking for, but I mean, what surprised me the most was the interest in IR. I think we were so used to, diagnostic residents and fellows, and sort of working with that pathway. But what surprised me the most was how interested medical students were in IR, and I'm sure Parag and Vicky and Greg will tell us a little bit more about this. But one of the things we were always concerned about was, would medical students want to do IR? And I think the answer to that is, overwhelmingly yes, but that surprised me the most.
Absolutely. Dr. Marx.
Hi, I'm Vicki Marx. I'm the Diagnostic Radiology Residency Program Director at University of Southern California. I've been the DR Program Director for just over 10 years. I'm also a full-time interventional radiologist, which I've been doing for 30 years. And I'm the Associate Program Director for our new integrated IR residency. We've matriculated our first PGY2 class just this July. And hopefully we'll get our independent residency approved at the October RRC meeting. What was the most surprising thing for me? The most surprising thing for me in becoming the program director of a very large residency was the amount of trust that residents have in me and the need to listen to residents who are managing pretty stressful, complicated lives and figure out how to help everybody succeed.
Dr. Patel.
Hi, everyone. My name is Parag Patel. I'm the Program Director for the Integrated and Independent Residency Programs at the Medical College of Wisconsin in Milwaukee. Also the Program Director of the Fellowship. I've been 10 years now, and the thing that surprised me the most when I became Program Director of a residency, as I'd been Program Director of the Fellowship for some time, that I think the stark difference to me between a residency and a fellowship is just the amount of administrative paperwork that's related to running one of these kinds of programs. And after a while, you really learn the ins and outs of this quite well because you're tasked with it as a program director, but it also becomes apparent that not everyone else really understands all of this as well as you do. So to Vicky's point, I think having these webinars and having these types of opportunities to reach out to trainees and our applicants and other program directors, quite frankly, are really helpful ways to disseminate the knowledge that most of everyone on the panel here has spent a lot of time learning at their local level. So thanks for having me today.
Thank you. And Dr. Walker.
Hi, my name is Greg Walker. I'm the Program Director of the Integrated and Independent IR Residency Program at Mass General Hospital in Boston, and just as the others, also the Program Director for the twilighting and eclipsing IR Fellowship. I guess in becoming a Program Director for the residency, just as Dr. Fischman said, I think, first of all, I had been worried about how much interest there would be, and obviously that's not something to be so concerned about at present. But the other thing I've noticed is I've had medical students come to me for mentoring and kind of trying to figure out everything from do I want to be an IR to how do I go about successfully matching, is kind of how much misinformation there is because people rely on traditional mentors in the medical school, people who don't necessarily know what the IR pathway is even or how it's designed. And so I would echo what Dr. Patel said, that these are really useful informational sessions because I think there is a lot of angst and misunderstanding about should I apply both to IR and DR? How do I rank programs? In what order do I rank programs? So on and so forth. And depending on who you ask, you may get totally different answers. So hopefully we can clear up some of that tonight.
Absolutely. I'm so grateful that all four of you are here. I can't wait to get started and exactly help clear up misinformation or answer things where I don't even know where to start. With that, we'll move right to the third part of the webinar. So basically there's going to be two parts where we're discussing with the panelists. One is going to be focused more on questions about before the actual application process, and then we'll move into the application process itself. So the first topic I'd like to start with is actually choosing IR as a specialty of interest. So on each slide, I'm going to have several questions, and I've told the panelists ahead of time they're welcome to pick and choose the questions that are most striking and compelling to them. So for choosing IR, the questions are, what are the most common reasons applicants say they're interested in IR? And are there any red flag or concerning reasons for an applicant to pursue IR training? And what do you recommend as the first steps for a student when he or she becomes interested for the first time in IR residency training? And would you propose different first steps for a preclinical student versus a clinical student? And love to start with Dr. Fischman.
Thanks, Santa. So I know we have a lot of topics to go over, so I'll try to be brief. The most common reason that I found that people say they're interested in IR is probably two or three things. One of the things that people will often say is, they're very interested in technology and device development and working with their hands, and they like surgery. These are all the things that that a lot of people will say. And then one of the things they dislike about surgery is that they don't like doing 6-7 hour cases in some of the more advanced surgical specialties, and they like the fact that IR uses imaging guidance, and they get to visually see things and work not only with their hands but visually as well. And so I think those are some of the most common reasons people apply. They also like diagnostic radiology, and they find this as a sort of an adjunct to diagnostic radiology if they have interest in it, to be able to still see patients and do procedures. And then lastly, I would say they do like seeing patients, and they love the clinical aspect of IR, which I think all of us would agree is probably one of the best things about our specialty. In terms of red flags, I would say people who really don't have a reason for going into IR, they sort of just check a box. I think we don't see a lot of that, but that would be a red flag to me. Or somebody who is just sort of trying to apply to IR because they're just trying to add on programs to apply to in addition to diagnostic radiology. And I think that's probably a red flag for me. And then lastly, what do you recommend as first steps? I would say early on in your clinical or your preclinical years to find an IR mentor. As Greg was saying, a lot of medical students will approach me and some of the other faculty at Mount Sinai to sort of discuss IR and what the future of IR holds and how it applies to them. And so I meet with students pretty much on a weekly basis to discuss those things. And if it's clinical years, we have a lot of opportunity for rotations, including electives, sub-Is. People can rotate through their surgery selective, which is something that is being discussed online, I think on SIR Connect right now, about how to set that up at your own institution. And I think there's a lot of PDs that are involved with that as well.
Mm-hmm. Thank you. Dr. Marx, do you have anything you'd like to add?
I think that I agree with Dr. Fischman that I'd say the big curb appeal that catches people's imagination initially with respect to IR is the kind of the modern technical aspects of what we do. I also think that once students get a little bit of experience with IR, they really enjoy the variety. Compared to other specialties, at least so far, IR has a tremendous amount of variety in the types of medical conditions and patients that we see and treat, and it's hard to get bored. With respect to red flags, the red flag that I worry about, I haven't really come across it, is people who want to do IR and don't realize that they have also got to be really interested in imaging, because that's such a core pillar of how we do our work. And as a diagnostic radiology residency program director, I also don't want residents in my program who for 3 years aren't going to do the core diagnostic radiology very well. So that's something I worry about. I haven't really seen it, though, because these are all excellent applicants that we get. With regard to first steps, I agree with everything Dr. Fischman said. I would also add that in the preclinical years, participating in an IR student interest group is a really good idea, and many schools have those now. And participating in a regional student symposium can also give people a lot better idea of what's going on in IR. With respect to the clinical years, I strongly recommend that people interested in IR do both a diagnostic and an IR elective or selective, or whatever your school calls it. And I think that doing even a sub-I would be a good idea. I don't think you should take your whole fourth year and just do IR, but I do think that having multiple exposures is a good idea. It does a couple of things. One, that gets the student better acclimated to what they're getting into, and if they get to know an IR faculty really well, they're going to get better letters.
That's an excellent point. And we're also going to talk more about IR rotations later in the webinar. So that's an excellent launch into that discussion too. Dr. Walker, do you have anything you'd like to add?
Yeah, just a couple of things. With regard to the first point of common reasons applicants say they're interested in IR, I think there is a perception, and I believe it's really true, that this is kind of where we're on the cutting edge of medicine. One of both curses and blessings of IR are that there are many people who are early adopters of technology that originated in IR, and although it's a concern that many people entering IR have as to whether or not what you invent is going to be usurped by someone else, there's always a sense that we're pushing the envelope at all times and that we are kind of the exciting new frontier in minimally invasive medicine, minimally invasive treatments. And so I think that's pretty appealing to people. I'll skip down to first steps when becoming interested in IR. I agree with everything that Aaron and Vicki said, of course. And I think the other thing is involvement, just as you guys, with SIR, attending a national meeting, seeing us from a national standpoint as opposed to a regional or a local standpoint, and kind of what the depth and scope and breadth of IR is all about. I think you get such a great view of who we are and how our specialty is evolving, how we have come from kind of a plumber mentality into a clinician mentality. So I would urge involvement in SIR and believe that also that will strengthen the application by being involved in the RFS and participating in many of the programs that SIR offers to medical students.
Definitely. That's we're launching into so many things that I'm eager to hear more about. So I think that's a great start. And we're going to go next to the preclinical years and step one. So as Wenhui already mentioned, the average score for step one for students applying into IR is pretty high. Mean and median are both about 245. And so it seems like step one, as much as I don't think we're overjoyed as students to study for it, it seems to be fairly important. So my question for Dr. Fischman and then Dr. Marx questions are, why is step one such an important part of the IR residency application process, And what advice would you give to a medical student interested in IR who was disappointed with his or her step one score? And then do you have any additional advice for preclinical medical students interested in IR besides taking step one seriously?
Well, I get this question a lot about step one, and step one is an important part of any residency application, not just IR. I don't think that, and I can't speak for everybody here or every program director, but I don't use step one as a cutoff. I know the statistics, and I know that pretty much everybody that applies to IR that meets the criteria that I sort of go by that I previously discussed will have a high step one score, but not everybody. I don't use a cutoff. I read everybody's application. I don't put in filters to remove low step one scores. That being said, people that have low step one scores, I would hope that there's a reason for it. And so if it comes up in an interview, let's say, we would potentially talk about it. And the advice I would give to a medical student is to take step two as early as possible and to do better. And I think we all know that step one, particularly in IR and what we do, and to the technical aspects of IR and the clinical aspects of IR don't always translate to a step one score, but it is a metric that we unfortunately have to use to grade how well people do on testing and knowledge base and things like that. The other thing that I'll mention about additional advice for preclinical medical students is to not just approach a mentor, but discuss with anybody that you come in contact who's interested or who's involved with IR, and to essentially get started on research projects, maybe get involved with device development if that exists at your program, get involved with the RFS, the Medical Student Council. Those are things that I always, I take that I think that's just as important as a step one score, the rest of the application. So the step one score is really just, one way to look into somebody's preclinical years, but honestly, that's really not the only thing. And you can ask anybody in any of the medical specialties how they use step one. You're going to get a different answer from everybody.
Fair enough. Dr. Marx, do you have anything to add?
Well, I, like Dr. Fischman, read every application and don't filter with step one scores. The way I've used step one is that it's a moment in time, and I usually look at a comparison between the step one score and the grades, the performance on clinical rotations and the performance throughout the preclinical years, because that's metric that's sustained over time. Hang on just a second. Hey, can somebody turn that off, please? Sorry, I'm in a public place.
Okay.
So a person who has a mediocre step 1 score and mediocre clinical performance, well, that's probably a low score probably means something. A person who does great on all their clinical rotations and has a low step 1 score, well, that's something happened at that moment in time. The one thing I have done for when I've been advising students at my medical school is if somebody has a long history of difficulty test taking and has never been evaluated for it, I think they should be evaluated before they take step 2 to optimize their ability to study properly for it. That's the only thing I would say different from what Aaron said. And I think that somebody who's disappointed with his or her step 1 score should seek mentoring from people in IR, not just in the student affairs and academic affairs of the medical school, because those people don't really have a clue yet about us.
All right, that's a great transition talking about the core clerkships as well. The next set of questions about the core clerkships and also non-radiology clerkships. So as a program director, how do you assess a student's performance on his or her clerkships? Does it really come down to the final grade versus the clinical grade or comments, the dean's letter? And then are certain core clerkships more important than others in terms of the student's performance? And if so, why? And then what advice would you give to a student similarly interested in IR who was disappointed with his or her grades on one or more of the clerkship grades? And then what is students' performance on a non-IR, non-DR, non-core rotation, so for example, a sub-internship? Would this have any effect on his or her application to your mind, and why?
I see, I'm first here, huh? Okay. Well, so on the West Coast, we have the luxury of just waiting till all the information is in before we send out. We always, send out interview invitations really late compared to the East Coast, and I think it has to do with the weather. So I do look at the final grade and the clinical grade. I also look at the dean's letter, and what I look for in the overall dean's letter and the student performance on rotations is consistency, because people who do consistently well, high passes and honors, tend to be just high-performing people overall, and that's just performance over time. I do take internal medicine and surgery more seriously than psychiatry, because as far as I can tell, everybody gets honors in psychiatry nowadays. I don't understand it, but I don't pay much attention to it. I do think that there are some rotations, clerkships that are really useful. I think ICU clerkships, anesthesia clerkships, hepatology, oncology, vascular surgery. It's all nice to see if people are focusing their elective time in areas that are pertinent to IR, but not everybody's that organized when they're a med student, and med students change their minds. So I look for consistency. Now, disappointed with a core clerkship grade. I've never had a student ask me about that. I do think that the more face time that students can get with IR faculty to demonstrate performance and to ask questions and have the faculty get to know them, that's a very valuable piece of their education. And so performance on non-IR, non-DR, non-core rotations, I just look for consistent behavior.
All right. Dr. Patel, do you have anything to add?
No. No, I'm just kidding.
It's the first time I've heard that.
So there's a lot to cover here on this slide, and I know there's a lot of topics we want to address following forward. So the things I'll just say quickly, I do look at all the core rotations. I do put a little bit more emphasis on the clinical rotations where they're interacting in a team setting, such as medicine or surgery, and even peds. Those kinds of settings, I think, can reflect a little bit more of the team atmosphere where you're going to do or be part of in the IR training programs. If we were to look at non-IR, non-DR, non-core rotations, I think to Dr. Marx's point, I want to see consistency, right? So like if you did honors in medicine and surgery, but then you were barely passing or even had, consistently like kind of low scores, but barely passing in some of these other rotations, I would suggest, maybe an effort issue with related to what you're interested in, maybe. In theory, you'd be interested in IR, so hopefully that wouldn't be an issue on those rotations. But you're going to be a DR resident for 3 of your 5 years, and you need to be able to show interest in that. So I need to know that you're able to take seriously kind of the varied things that you may have a passion in, but also the things that are your professional responsibility to do well in, even if you're not, it's not the thing you want to go into primarily. So I think it tells me a trend. I don't look at any one score and say definitely in or definitely out, but I do think that if you look at the totality of preclinical years and then your clerkship scores, you tend to see trends. And I agree that the STEP score is just a moment in time, as Dr. Marx had described it. So, and I think that's all I got to add to that. I think you just got to try to do your best with each of them. Don't be so bogged down with one bad score. If you're disappointed in one of your core clerkship grades, you've got hopefully the others are more reflective of your experience, and then your early M4 rotation scores will have some effect as well. And you certainly have to do an IR rotation. I think if you're going to be applying to the IR residency, for program directors to think that you seriously understand what IR is all about.
Okay. That's another great transition actually to our next topic. So for IR and DR rotations, we've discussed some aspects of this already, but for applicants to an IR or DR residency, are any of the following red flags: not doing a home IR rotation or an away IR rotation, or not doing a diagnostic rotation? And then how do you assess a student's performance on one of these rotations? Do you look primarily at the grade or comments or letters of recommendation from this rotation? And how important is this performance for the application? And then additionally, if a student completes an IR or DR rotation after the ERAS application is submitted, how could this rotation affect that student's application to residency? Starting with Dr. Patel.
So I don't give well, as far as the first question, no home IR rotation, no away IR rotation. That's variable. I've come to learn that not all medical schools have a formal IR rotation at their home institution, so we can't penalize a student for that. Secondly, I've also learned that it's not always easy to get an away IR rotation because they're competitive. As many applicants as there are, I think many of them know that they need to do these rotations or try these rotations, and many are seeking out an IR rotation. And for instance, we have several applicants for every month that we offer, and we can only have so many students on service. So there are many months, and I've had students I'm advising here at the medical college, and they're having trouble getting into certain away IR rotations on ideal months in advance of their application cycle. So it's hard to really penalize an applicant for not getting one or the other, but certainly an IR rotation needs to be had, I think, because personally I think it would be hard for me to believe that you understand what interventional radiology is all about if you've not spent anything but perhaps shadowing time in the field, and then for me to commit 5 years or 6 years in our program to interventional radiology, and then later find out that you kind of liked it but don't really understand it and maybe aren't interested anymore. It would be very difficult. So I do think you have to find a way. I don't have a good solution for those that don't have a home IR rotation available to them and have trouble getting an away IR rotation. That unfortunately is a problem. As far as performance on an IR rotation, I do look at the letters. I would like to see a letter perhaps that helps indicate that the interventional radiology faculty got to know that student and can speak candidly about them. I don't necessarily think any IR letter is valuable, meaning just a letter from someone in IR who doesn't really know you is not nearly as valuable as, say, the medicine or surgery faculty who worked with you very closely on either a project or over the course of a rotation and can speak truly about your character and your qualifications as a future trainee. So it's really more important to get a quality letter from someone that knows you than just a letter from IR. Although if you can get both, meaning a quality letter from interventional radiology faculty who you rotated with, that's the ideal situation, I think.
Mm-hmm, mm-hmm. All right. Dr. Walker, do you have anything to add?
Yeah, actually, a couple of things. So I completely agree with Parag that I don't think these are red flags, not having a home IR rotation or an away IR rotation. But I think when, and circumstances can be difficult, I agree to sometimes have these on one's CV. But I think that if we're being totally honest, as program directors and as people who read applications, I think that it just weakens the application somewhat. If for a number of reasons, that maybe you have someone who doesn't, as Parag said, fully understand what IR is all about. They haven't had a chance to kind of test the waters, and they haven't had the chance to work with a dedicated IR mentor that one of us might actually know. And so when you're looking at letters, for example, I do look very closely at those. And so a very, very strong letter from someone I know, really showing the virtues of a particular medical student, carry a lot of weight. But so too would a really good letter from a surgeon or a medicine doc, as opposed to just a boilerplate letter that just basically says someone rotated and they were satisfactory. So I think when possible, actually testing the waters and participating in IR rotation is great. I don't necessarily think that it needs to be something at home, although you can view that if you are someone looking at medical students rotating through as a little bit of a test drive, both for them and for you. You know how they perform. A medical student that I know personally and who has rotated at my institution obviously has at least some qualities that I'm much more aware of than someone that I'm just looking on paper and trying to decipher from letters. As for your last point, after a DR rotation or an IR rotation is completed, once the submission's been made, how can that rotation affect a student's application? Well, there are some students who perform so exceptionally well that if they indicate to a mentor, I really, really want to match at this particular program, there's also nothing wrong with having that mentor pick up the telephone and call a personal contact and just say, look, this wasn't on their application, but I have to stress this young man or this young woman was absolutely fantastic. They performed so well. So, there is that option as well as just through the formal submission, I believe.
Mm-hmm. All right. Great. And then we have a couple more questions about the IR and DR rotations, sort of more specifically to your own programs as program directors. So to what extent would the following make a student more attractive to your program, either an IR rotation in your geographic region or an IR rotation at your institution? I think we touched on this a little bit already. And then for students who enroll in IR rotations at your institutions, what do you see as some signs that indicate the student would be a good fit for your IR residency program? And do you look for different things in home versus visiting students? And then what are common mistakes you've seen students make during IR rotations? Starting with Dr. Walker.
So I don't think it makes the student particularly more attractive to me if they are in my geographical region. As I mentioned, an IR rotation at my institution does allow me to personally assess, as well as my other faculty colleagues, to assess kind of how that person measures up as compared to other people rotating through. So I think a good performance at my institution, obviously that maybe sets a little bit of a bias, but as I said, it's a little bit of a test drive. And so I think that's very, very useful, but I don't necessarily think that because someone's from New England or from Boston, that's going to make me want to necessarily say they're the only people I'm interested in. I actually really love the diversity of IR and the diversity of having people from different medical schools that bring different viewpoints from their schools, different perspectives, geographical, et cetera. So I see that as kind of a strength, having some diversity. I think Signs indicate a student would be a good fit for our program, and Aaron alluded to this earlier, is kind of the whole teamwork sort of thing. IR really is very much about teamwork. It's not just the docs, it's also the technologists and the nurses and the advanced practitioners, other ancillary people that all work together to really make us a success. And so for a medical student to kind of be able to jump into the framework of a team and see how they can bring added value as a medical student to assisting the fellow or assisting a resident or assisting a staff member, that really shines and that really stands out as we're watching people and how they perform. And actually a common mistake, let's say there are 2 or 3 people in a clerkship, is the overly aggressive medical student, the one that might actually want to kind of appear the most intelligent or the most industrious, but at the expense of the coworkers. Radiology, interventional radiology, it really is very much a team sport. And we really love to bounce ideas off of one another, and we really like to have input from one another. So someone that's kind of out of step with that, I think that's going to be a big mistake during an IR rotation.
Interesting. Dr. Fischman, do you have anything to add?
Well, those are all really good points. I agree with all of them. In terms of geographical location, I don't think it really matters. We have luckily for us, we're in New York, and so we don't really have an issue with people wanting to come from other places around the country. But at the same time, I don't want to take all my candidates, all my students into my residency that are from New York, and I actually prefer to have a very diverse, not just in the types of people, but from where they're from. I think it makes for a much better residency program. So I do try to create not only personal diversity, but geographic diversity. So it's really important for me. It's always good to do an IR rotation at your institution. You should do as many as you can, as everybody has been saying. If you don't have the opportunity, I think there's ways to seek them out. You can always make, if you don't get a rotation that you want, you can always make a call to a PD or the program coordinator and see if you can, find a spot sometime that you have available. So there's always ways to do it. I think it's critical for us as program directors to meet people and to not just rely on interviews, because we sometimes are wrong about the people that would fit, not necessarily about the quality of the candidates, because obviously the candidates are, for the most part, beyond excellent. It's for us trying to figure out how well you fit into our program. And so one of the things that we look for is, do the students interact well with the fellows and the residents? And I shouldn't really say fellow anymore because it's not going to be applicable, but do they interact well with the faculty? Do they interact well with our PAs? It's important to me that my PAs and NPs like the candidates, and I actually have them interview the candidates, because we spend a lot of time with our mid-level providers, our advanced practice practitioners, as a lot of people call them. And I want to make sure that they agree that they should be at our program. And so it's important to meet everybody and to meet the people that work behind the desk, and people, and the nurses and the techs, and do the techs like the students? Are they rude when they go into the room? I mean, these are things that, these are little things that we may not pick up on from a journal club presentation, but people will let us know that this student is really excellent and they interact well with the staff, and that's what I look for. Common mistakes would be to not interact and to be sort of more passive. I think what bothers me the most when students come is that they really don't spend a lot of time interacting, and they're not as aggressive about going in to see cases and to see patients and to round. And those are things that I'm not going to go and tell students to do. I think a lot of students do that on their own. But if you have to sort of beg people to do things and to be interested, then that's not the right person for our program. So that's probably all that I would have to add to that question.
All right. And then next, we're going to talk about a topic that often comes up with IR pushing more and more clinical trials and other research. So as a program director, how important are the following for applicants to your residency program, and why? So having any research experience, and then if that research experience is clinical or translational or basic science, and then whether that research is in IR or radiology, but not IR, or not in radiology at all. And do you have any advice for how to describe one's research experience on the application? And how do you sort of assess applicants' potential as a researcher? Is it number of publications, or is it comments from the person's research supervisor, things like that? Starting with Dr. Fischman.
People always ask this question about research and is it required? And it's a sort of a silly question because research is never really required. It shouldn't be required. That being said, we want people in IR, and I think we all would agree, that want to advance our field, that want to develop new techniques, that want to do not just clinical but translational and basic science research because we care about the future of our specialty and advancing it. And so if our future trainees have absolutely no interest in that, then it probably is not the right field for them. Doesn't mean that you have to do all of your research in IR. There's a lot of people that have spent a lot of time in other specialties researching, and maybe even a lot of research in other specialties, which is fine. But for me, I look for people that have dedicated some time, not necessarily research, but dedicated some time to understanding the field and trying to advance the field and really caring about it and not just doing research to put something on their CV. In terms of describing your research, I think you need to be very accurate, and I think it needs to have, there has to be some reason as to why you're doing it, and not just to check a box. I think it's important that you have a good mentor, and so if I was going to assess somebody's accomplishment and potential as a researcher, I would probably talk to whoever their mentor was and say, is this person a good candidate? And I think if you do research with a good mentor, they'll be able to not only write you a good letter, but also vouch for you when you start interviewing.
Dr. Marx, do you have anything to add?
Not a whole lot. I agree with basically everything he said. I will say that in this day and age, an ARAS application that's completely blank on the topic of what they call a research or scholarly activity or publications and presentations, if that box is completely blank, it stands out, because most medical schools, have something where you can get a poster on the student research symposium or something. So to me, if there's absolutely no research experience, it implies somebody who's getting through medical school doing the least amount possible. But I am not a researcher myself, and I don't delve too deeply into what the research is, but I always, as in the interview, ask people to, one of their topics, if I think it's something I might understand, I'll ask them about it, and it's very obvious when somebody's had meaningful experience on that research project, or if they were just doing it to fill the box. You know what I mean? I would say it's rare that research is just because of the nature of the program that we have, that research experience is a primary aspect of the application, but it's a component that we do look at.
All right. And then another component that seems to come up for the application is, which we already touched on a little bit, is leadership in IR. So as a program director, how important are the following for applicants to your residency program? So we already touched on some of these things, but involvement or leadership within the SIR-RFS or MSC, or within one's home IR interest group or regional symposia, and then leadership not directly related to IR. And then if you have any advice for describing, that should say leadership, one's leadership experience on ERAS, and then assessing an applicant's leadership potential, starting with Dr. Marx.
Well, I would say that leadership, I would probably look at leadership more as a more important component than research, just because of that's who I am. And there's so many opportunities for students to get involved in the MSC or the RFS that it sometimes, if they've had no experience either locally or nationally in some sort of IR group, you kind of wonder why not, right? But I look at other kinds of leadership too. I think a really important component of somebody's performance in medical school is the people who get the Gold Humanism Award. I think that's a big deal. I think there are students who participate in other leadership aspects in medical school or outside activities during medical school or before medical school, and I view those as all important. Sometimes I raise my eyebrows a little bit if there's no leadership activity or no participation activity in the IR type things you list here, but I view other leadership experience equally valuable.
Okay. Dr. Patel, do you have anything to add?
So I will comment on this in that with the how large the Medical Student Council and the RFS has grown, to have some involvement or leadership within that, or your local IR interest group, at the local medical student level, and helping to organize that, or getting involved in regional symposia, I think are great ways to demonstrate to a program director who's reviewing your application that you get IR, at least at a surface level, that you spent the time, you were committed to it. It gave you an opportunity to learn more by way of being involved or even leading in any one of these endeavors. You learn more about the specialty. You interact with other faculty, but also other students who also are very much engaged in learning about interventional radiology. And I think that interaction, that leadership, that involvement lets me understand that the applicant has a better understanding of what our specialty is about, or at least has the potential to, as opposed to someone who's had zero involvement in that. And I emphasize the word involvement because I understand that leadership, the opportunities to lead on a committee may not be available to everyone. Certainly, if there is, over the course of 4 years of medical school, and you work your way up into a leadership position within the MSC, that's wonderful. But certainly at your local level, there's an opportunity to do that, and I do think it is important. I do value seeing that on an application.
All right. With that, that's actually our last specific slide about advice before an applicant applies. So before we move on to the next section, which discusses the application process in more detail, I'd like to ask our panelists if they have any additional advice for medical students before they start the application process. If there's a slide you wanted to comment on and did get a chance or anything like that. Starting with Dr. Fischman.
I think you need to, I think all students need to ask themselves one question before they apply to any residency is, do they really feel passionate about it? Is this something that they're going to do for the rest of their lives? And if the answer is absolutely, then they're going to do fine. If the answer is I'm not sure, then they have to look a little bit further. They have to do more. They have to do, work with more faculty, do more rotations, try to understand if IR is really for them before applying. Because again, you're not going to be happy in your career if you pick something that you're not passionate about. And so you really have to delve deep within yourselves and try to understand why you want to do IR, and if you're doing it for the right reasons, then you're gonna get a good residency and you're gonna be very happy. Everything else that we've said tonight, I think, applies, and these are all sort of basic questions that students are constantly asking, but really what they need to ask themselves, and what students always sort of forget, is do they really feel passionate about IR? And for the overwhelming majority, the answer is yes, but some people it's not, and I think those people probably shouldn't be applying to any specialty that they don't feel passionate about.
Absolutely. Dr. Marx, do you have any additional advice for the pre-application process?
Oh, I think all medical students, before they start applying, should take a deep breath and acknowledge that they're valuable human beings and try to do whatever works to mitigate their anxiety. I think it's a tremendously stressful period of life.
I can agree with that. Dr. Patel, do you have anything to add?
I think we're going to talk about the application process next. I was going to just comment on two things. One is and I think this touches on what Dr. Fischman was trying to maybe getting at, is just taking stock of what you really want to do with your career, and what is the, knowing the competitiveness of the specialty, what are your opportunities, and sort of realistic expectations. It's not to say that if you really are passionate about IR, but you don't think you stand up to the numbers that were presented earlier on this webinar, I'm not trying to suggest that there's no shot for you, but then you have to look at other potential routes or ways in which you can improve that application to pursue your passion. But if you're not truly passionate about it, and it is a very competitive application process, then maybe reconsidering and finding out where that passion lies. And then I was going to touch on, before you really start the application process, to get all your ducks in a row, and I think you'll probably touch on that with the next session, but just to be organized with all of that and being timely with things is going to be very critical, and having a plan and process before you start the process is going to help with that, including letters and so on.
Absolutely, yeah. We're going to touch on that in more depth. So everybody's done a great job of sort of previewing where we're going next. Dr. Walker, do you have anything to add for medical students before they start the application process?
Yeah, I think we said at the very beginning of the webinar, a really good mentor. It is very competitive, and a mentor who can sit with you, look at your CV, look at what you've done thus far, help you kind of look at how competitive you are, how do you strengthen your application, what sorts of things can you tweak a little bit to be as competitive as possible, and just to have someone guide you through this process and be a listening post and a source of advice.
I think these are all great things to hear as a student. So with that, we'll dive right into the application process itself. So part 4, so starting, going right ahead with letters of recommendation. So what should a student consider when deciding who to ask for a letter? And then what are the most important things that letters of recommendation tell you as a program director about an applicant? And then for applicants to IR or DR residency, are any of the following concerns, such as no letters of recommendation from an interventional radiologist or diagnostic radiologist, surgeon, or if all the letters of recommendation are from interventional radiologists and from no other physician in no other field. And then would you recommend assigning different letters of recommendation to IR programs versus DR programs? Starting with Dr. Patel.
Sure. So first thing, when a student considers who to ask for a letter writer, I absolutely should be someone that they know can write them a strong letter. Not just any letter or a letter, but a strong letter. And that usually comes from some faculty that's worked with them closely, whether it be on a research project or on a rotation. I think I touched on this earlier. But when I read a letter of recommendation from someone that clearly knows the applicant, they usually will explain the interaction or the relationship that they have with the applicant. It may be very brief, some are research project or a publication they're working on, or over the course of 8 weeks or even years in which they've interacted with the candidate. So that tells me, one, how candid they are going to be and how well they know this applicant, not just a 2-week rotation or perhaps worse yet, a few shadowing experiences with the trainee, and then comment on it, because you can quickly tell what is a standard letter of recommendation with standard language as opposed to one that is truly candid and speaks. I don't know what to take from the latter, or the one where it's a standard letter where I don't have clear indication that the letter writer knows that person well. So they're just writing kind of a block letter that has minimal to no value. Whereas someone who has a strong letter or knows the candidate well, I can really feel that the comments are true to the actual applicant. And so that's important to me. Now I realize that means that not every applicant's going to be able to get one of those strong letters from an interventional radiology faculty. And even if you've done an IR rotation, you may not, because you may not work with one faculty enough to know them well. Hopefully you do, and hopefully you focus during that month to have meaningful interaction consistently with 1 or 2 faculty that would hopefully provide you that opportunity to get a letter from them. But if you've done 1 or 2 IR rotations and you have stellar letters from your clerkship rotations from a surgeon or an internist or a hepatologist or someone you spend some time with, or the summer research person you worked with for 4 months. That's going to have value to me, and so that's much more valuable to me than just having all letters from IRs, assuming that they're not strong letters, they're just standard letters. But like I said earlier, if you can get a really strong letter from an interventional radiologist, it's a small community, we tend to know people, we have no problem calling and following up on those kinds of letters. That's wonderful too, but don't lose hope if you don't have a letter from an IR faculty alone.
Okay. Dr. Walker, do you have anything to add? Dr. Walker, do you have anything to add?
Yeah, I do. Just to echo what Parag said, if you when you decide who you want to ask for a letter of recommendation, I think you have to be absolutely certain that it's someone who will put together a letter that actually gets to the heart of who you are and how you perform. And if that's a surgeon, that's great. If it's a medicine doc, that's great. If it's an IR, yeah, that's even better. But it might not necessarily even be an IR with whom you did the away or the home rotation. If you've done quite a lot with SIR and with the RFS, maybe that's someone who might write a strong letter about your leadership abilities. It doesn't have to all be about what your clinical performance was or what your clerkship performance was. But I think the most important thing is indeed for it to be a strong letter, and one that just doesn't check a box that I have an IR letter, I have a surgical letter, and I have a DR letter. I don't really see any reason why you would need a different letter of reference or letter of recommendation for the IR versus the DR program, just a strong letter.
Okay. All right. Next topic is the personal statement. So as a program director, what are the most important things that an applicant's personal statement can tell you? What are some common mistakes that applicants may make in their personal statements? And then along similar lines, would you recommend writing distinct personal statements for integrated IR residency programs versus diagnostic residency programs? And if so, how different would you recommend to make them?
And I think I'm to speak first, is that right?
Mm-hmm.
So, yeah, I think a personal statement can really give you a window into a number of things, and people write different types of personal statements. Often, because it is an application for an IR and or a DR residency position, people really touch on compelling reasons why they are choosing this specialty and how they hope to affect change in their patients or through their research or those sorts of things. And so I think people really do need to give a lot of thought to their personal statement, speaking to kind of what drew them into the specialty, what they hope to accomplish in the specialty. But I think one of the other things is, just trying to be a bit practical. I do just as all the other program directors have said, I read every application. I won't say that I go through and read every personal statement from the beginning, because there are other things that I first look at carefully to decide how deeply to delve into things. But whether you read every single personal statement or a handful of them, one is to have one that's actually readable. And by that I mean something that doesn't ramble through 2 or 3 pages, but something that is reasonably succinct, that gets to the point, that really puts forth 1 or 2 central ideas in a kind of cohesive and non-rambling fashion. And I have seen some personal statements that just tend to go on, and you get a bit bogged down in those. I don't know that there need to be distinct personal statements for the IR versus the DR residency programs. I think that just speaking to the heart of how you feel about yourself as an individual, as a physician, and as a potential interventional or diagnostic radiologist is kind of the heart of what should be touched upon.
Mm-hmm. Mm-hmm. Okay. Dr. Fischman, do you have anything to add?
Well, that was all very accurate. I would say, I agree with Greg. I can't read every single personal statement because there are some applications that I look at other things first, in particular letters of recommendation. That being said, when I read the personal statements, the ones that are most interesting to me are the ones that, maybe this is just my bias, but talk about either strengths of their character, strengths of their application, and then also talk about maybe their weaknesses and potentially some reasons why they like IR. Those are probably the most common ones, and those are the ones that I sort of get the most out of. Anecdotes about interesting things that have happened in their lives and reasons they've gone into medicine, I think are fine, and I think that's what a lot of people do as well. They're really, I don't know that there's mistakes that you can make, except for the, like what Greg was saying, not being readable. I know people that have talked about, big mistakes they've made in their life, and I think that's important to be able to understand your own personal weaknesses, and I think that's a good thing to talk about in a personal statement. I definitely would not recommend writing two personal statements, one for DR and one for IR. I think it becomes very clear that people that are doing IR integrated applications are not applying specifically just for DR, and so I think it would probably be pretty silly to do two personal statements, because all DR program directors know who's applying for IR and who's not. And so I don't think it makes sense to sort of describe why you want to do DR when you're really applying to DR and then potentially doing IR as well. So that I would recommend against. Customizing, it's important to be personal and to be honest, and it comes through in the personal statement. So it really is, like Greg was saying, the window into somebody's personality, and without meeting them. And again, when you meet somebody during an interview, you can sort of see why they said what they did in their personal statement, if it's one that you remember very well.
Wow. I'm actually, so that actually goes very well with our next topic in terms of finding a good fit for your personality. So based on your experience as a program director, what do you think is the best way for students to decide how many programs to apply to? And then related to DR and IR, is it common for an applicant to be less attractive to diagnostic programs because he or she is interested in IR? And is there any way for the applicant to mitigate this if this seems to be the case? And then before interviewing, before meeting the program director and other members of the program face-to-face, how can an applicant find residency programs that are a good match in terms of competitiveness, but also in terms of personality?
Wow. Okay. Those are interesting questions. The first thing I'll say is there really are only 4 programs that everybody should apply to. It's New York, Wisconsin, Boston, and California. But in all seriousness, I think it's apply to as many as you think you would want to go to. I wouldn't apply to programs that you don't want to go to. I think there are some places in the country that people have ties to, and I think that goes a long way, particularly when you're interviewing and you have ties to that particular area. So I think it's good to concentrate around areas where you'd be happy living, where you have family, and I think program directors are very attuned to that. In DR, I think if you want to do IR, you really should be applying to DR programs that are going to offer an independent residency or at least an ESIR program. And I think we're not really talking a lot about that tonight. But most of the positions that are going to be available, at least in the coming year, are probably going to be available through ESIR, and so that's a critical part of our training, and I think it's important to not forget about that. The question about being less attractive to DR programs because you're interested in IR is a difficult thing to answer. I think there are some situations where DR program directors, and this depends on the program, but DR program directors will make it a point to not match too many people in their program that are doing IR, because it puts them in a very difficult situation in the sense that they won't be able to offer ESIR for all of those candidates. And so that would be not great for the people in the residency. It would also be not great for the program director to have to deal with that situation. And so this may, in some scenarios, bias program directors or DR program directors against IR candidates, it really depends on the particular program and how many people are interested in IR at that program. There's no way, I don't know if there's really a way for the applicant to mitigate this, and I think it's important to keep in mind that ESIR is just as important as a training pathway as integrated, and to not forget about the two pathways, and explain that to both program directors, and make sure that you're honest with your goals and how you want to approach that situation. It's a difficult question. I don't think I answered it, but that's the best that I can do.
No, no, just it. Thank you.
And then before interviewing, I think you need to talk to your mentors and say, hey, how competitive am I? Which program should I apply to? What do you think of this program? And we would hopefully be able to give you good advice as to where you should apply. I think we've all done that. We all do that on a daily basis when we talk to medical students and try to tell them, what we think good programs are for them. And so it's really something that, depends on the person. And I have that conversation with medical students.
Dr. Marx, do you have anything to add?
I have no clue how many programs people should apply to. I have told medical students that they're enough in debt that how much it costs to apply to enough programs to make them feel at peace should not be where they try to save money, I recommend to students currently who are interested in IR that they do apply to both IR and DR, because there are two pathways to have an IR career, and the integrated pathway is not accommodating all the people interested at this point. As a DR program director, I look very carefully at everybody, and I do think that the way for people who are whose primary career goal is to be an interventional radiologist, but who are going to perhaps do it through the diagnostic radiology and independent IR residency pathway, that it's important for them to do diagnostic radiology rotations or clerkships, and to be able to decide if they're enthusiastic about imaging and communicate that to DR program directors, because that's the piece that if you can effectively communicate enthusiasm and knowledge about imaging to DR program directors, I think that the perhaps negative perception that a few may have will be decreased. As far as how to figure out what's a good match before you interview, I totally agree with Dr. Fischman that talking to your mentors is a good way to start. But really, figuring out the personality of a program is something that happens during the interview. Figuring out that good match and where you feel comfortable, I think, is really the most important aspect of the interview itself. So I'm apologizing. I'm going to need to sign off early. So I appreciate being a participant in this webinar, and I'm sorry I had to yell earlier once because it was noisy here. And thank you all from the student group for organizing this. I know that all the applicants appreciate it. Thank you very much. Bye-bye.
Thank you so much, Dr. Marx. And in the interest of time, I promise it's nothing personal, Dr. Patel. I'm going to skip the next two slides just to jump right into the interviews. So we're going to skip over before the interviews and the intern program and jump right into interview day questions. So on the day of the interview, what are the most important things that you can learn about an applicant? What type of interview questions are guaranteed to come up? And then what types of interview questions seem to be the most challenging for interviewees, and why? If Dr. Walker, if you could start with this set of questions.
Yeah, so the whole process of an interview is a difficult one. I think we all acknowledge that. And depending upon kind of how your interviews are structured, do you have 20 minutes, 30 minutes, longer than that with an applicant? I kind of see this some kind of twisted form of speed dating or something like that when you're interviewing. But what it does show you, I think, in as much as you can tell within a short period of time, is kind of just a sense of how the person interacts with another individual, how well they're able to articulate, and I'm going to jump around with some of the other questions, what is it that has attracted them to IR? Why is it that they view your institution as one that might be a good fit for them? That's usually something that people will ask. Why in my institution, for example, are you interested in coming to Mass General Hospital? What is it that piqued your interest about our program? What do you know about our program and why? I think kind of thoughtful answers and thinking very carefully about the institution where you are interviewing and knowing a bit about that shows that you actually have given thought to why indeed you would want to potentially undergo your training at my institution or Aaron's institution or Parag's, et cetera. And so I think those tend to come up very often about why interest in IR and why interest in a particular institution. Oftentimes people will, from the DR side, because we oftentimes will interview IR and DR, there will be questions about kind of your level of interest in diagnostic radiology. Just as Dr. Marx has said several times tonight, for me as a program director, it's very important that the IR residents who match to my program perform exceptionally well in diagnostic radiology. I would like for them to equal or surpass their diagnostic radiology colleagues in terms of their enthusiasm, their engagement, and that sort of thing. So I think questions will come up also about diagnostic radiology. Is it a means to an end to just become an interventional radiologist, or is that an area that you're going to have particular interest in, and you see that as a great part of being a good interventional radiologist, being a great diagnostic radiologist as well? I think some of the challenging questions for people who are being interviewed are ones where sometimes people will ask you to describe your greatest strengths. Why would you be someone that we would be interested in having in our program? And sometimes people ask you about, weaknesses. Dr. Fischman alluded to that, when you're able to say, I recognize this as something that I have troubles with and that this is how I work to overcome that. So I think sometimes those are questions that throw people a bit for a loop.
Dr. Fischman, do you have anything to add?
Well, the interview is it's really the only time that we get to really talk to people that we think are impressive on paper. And a lot of times we are surprised that people who we think we know a little bit about them on paper were wrong. And I've been pleasantly surprised in many instances, and I've been disappointed to meet people who I think are going to be some of my favorite candidates when I see them on the interview day. The first question I ask is, do you follow us on Twitter? And if the answer is no, then the interview goes pretty quick. Now, in all seriousness, I think the types of questions that I ask are typically about them, why they chose IR, why they want to come to Mount Sinai, what they really envision themselves doing in their career, and then I try to assess whether I can train that person to become what they want to do, or what they want to be. And there are situations where I don't think that Sinai will be the right place for them. Not that they're not a great candidate, and I think that almost everybody is a great candidate. But I'm trying to pick people that I think will fit in. So the biggest questions that I like to ask are the ones that things that we talk about on a daily basis. How do you approach this complicated problem? Do you envision yourself having a clinical practice when you finish that's robust? What do you think makes a good IR? These types of things that most people that are interviewing for IR should have answers for. There's no right answer, but I think there just needs to be an answer that's cohesive. And so I'm looking for that type of person that can answer these questions without really having to sort of concoct something that they maybe wrote down on a piece of paper. It should really come from within, and that's sort of what I like to get at when we interview people.
I'm actually going to skip over part 2 because I think we covered a lot what we want to cover for interviews. So for after interviewing and for the ranking, are there any good reasons for an applicant to contact your program after the interview but before the submission of the rank list? What's most important to you when you're deciding which applicants you'll rank most highly? And do you feel that what's valued varies between programs? And do you have any advice for applicants? We've touched on this a little bit already about the rank order of integrated IR programs versus DR only programs. Starting with Dr. Fischman.
Well, good reasons to contact your program would be if you have significant interest and you want to make that clear. You know, I like getting emails personally. I don't. I know people like to write letters, but I do like emails. I find that's easier for me to put that into someone's file. And then when I go back to ranking, I like to look at emails that people send and try to understand how interested they are in our program. Again, the things that are most important that I sort of try to figure out during interview day and then reading applications and then thereafter is will they fit in and do they want to come to Mount Sinai? And I think we all look for this. We all look for people that we think are going to fit into our culture, and everybody's culture is different. And we sort of figure that out during away rotations. We see how people fit into our culture. We see that on the interview day, how well do people interact with the current trainees, and the current trainees do have some input when they speak to a lot of the candidates. And so, you know, it's not just interviewing with faculty, and it's also the trainees that we like to see how they interact with them as well. In terms of the rank order for IR, DR, and DR, and I've had this conversation with multiple medical students, if you like a program, you should rank IR #1 and DR #2, and that's the way that I would recommend people do it. There are a lot of candidates that will just only rank IR programs, you know, 1 through 10 or 1 through whatever, and then they'll rank DR after that. I personally think that if you like a program, you should put DR right after the IR program, because there should be a pathway for you to come and do IR at that program. It may not exist everywhere, but I think it's important, if you like a place, that you should try to do the ESIR pathway there. And that's the way that I tell people to rank them.
Dr. Patel, do you have anything to add?
Yeah, some of the same comments, actually. Reasons to contact. I mean, it's not unusual for every applicant to give, you know, a thank you or thank you for interviewing kind of courtesy email, but a follow-up email that's relevant would be, maybe there's something new in your application you need to share with me that may have relevance or importance to you that wasn't part of the original application, or just a way to convey your strong interest in our program. Now, that being said, you don't send that same degree of a strong interest letter to every program. I can't tell if you are or not, but you know, clearly we're looking for candidates that recognize that this is truly a good fit, meaning our program. Our programs are not all the same, and you know, whether it be the mix of faculty, the institution, the geography, and so forth, those are things that hopefully resonate with the applicants, and then they can let us know, and that might be helpful. It's helpful for me as I consider a lot of strong applicants to see which ones I thought fit well with us, and if in turn they also corresponded back with me with similar comments. As far as advice on ranking applicants, I agree completely with Aaron. I don't believe the students that I've advised, I don't advise them to rank all IR programs first and then all DR programs. I think it needs to, a good, thoughtful rank list probably has a nice mix of IR and DR, and not all IR and then all DR. Because if you truly are looking for the best fit for program, you know, our program is like many of the others of the panelists. We have, you know, the integrated residency, we have the independent residency, and we have the ESIR. So a DR resident in our program currently, a first-year DR resident, has essentially the same exposure to IR as our IR resident. The only difference being is they have to go through another match, but they have access to all of the same faculty and all the same resources for research and education, and are essentially getting the same first 4 years of education, assuming they're going to do the ESIR and they want to pursue that, as our IR residents. And I will tell you that I'm sure there are some IR residents that, you know, thinking about it in those terms would say, yeah, maybe I would have preferred to do that, that ESIR program But the reason the IR residency seems like the way to go is that it guarantees you have your IR training set. But it may not work out if you don't get into an IR residency and you end up going to a DR residency lower on your rank list as opposed to the DR residency at a much stronger program that you had resonated with you. So I just wanted to emphasize that point again.
Dr. Walker, do you have anything to add?
Well, I would just echo what Dr. Fischman said. Although having a handwritten letter is really lovely, and I know that's kind of a lost art these days, I really do prefer things coming by email. It is something easy to file, easy to access. And I do think the follow-up contact is appropriate, particularly if you're expressing a high level of interest. The thing is, just as everyone else has said, we really want a good fit, and our culture may be and is very different from the cultures of the other program directors who are on the panel tonight. And so part of the whole process is for the applicant to decide, do I just get this gut feeling that I could be happy here for the length of my training, that this is a place that is conducive to kind of my learning style, the residents seem happy, the faculty seem approachable, those sorts of things. So if that really resonates with someone, kind of reflecting that in a follow-up letter and saying, for these reasons, I intend to rank you very highly, or you're, my top choice, that sort of thing. Those are things that we love to hear because it kind of helps us, because fit is so very, very important, particularly in a residency as opposed to a fellowship where someone's going to be with you for only 1 year. I also agree with ranking the programs that really resonate with you, but I also would just add one caveat, and that is kind of know the strength of your application. Again, we've got phenomenally well-qualified applicants, but if if you have this sense that a program might be totally out of your reach, then maybe go for something that actually is within your reach. You might be a Mercedes-Benz at one program, but a Rolls-Royce at another one. And I think to actually, with your mentor, take stock of kind of how competitive an applicant you are for certain places might help you realistically structure a rank list that would give you the most chances for matching into IR.
Well, with that, we just have one more set of questions. Basically, actually, I'm going to skip ahead to the next slide, actually. So the last set of questions we have is about unique characteristics and last set of advice. So there's no typical applicant to residency. So I wanted to ask the panelists if you have any special advice for applicants who are international medical graduates, DO candidates, couples matching, or other special situations you can think of. And then the last formal question before we open up for questions from the audience is, what's the most important piece of advice that you would like to offer to aspiring interventional radiologists who are applying to the IR residency?
Well, IMGs, DOs, these are all, the same advice applies to anybody who, if your application is good and the same characteristics apply, again, like I said before, I like to read every application without any filter, because a lot of times, if we use filters, we miss a lot of great people, and I think a lot of those people fit into those categories. In terms of couples matching, I couples match when I was applying for residency, so I understand the nuance of that quite a bit. And so if people are couples matching, I like to hear about it and discuss why they want it, why they both want to come to a certain program. The luxury of being in a major metropolitan area is that you can couples match at different programs, and I think that's important for New York City, and I know for Boston as well. And so that works out well for our program. So I don't really think I have much else to add than what we've said previously. So I'll just end with that. And I really want to thank everybody here for the invitation, and hopefully this was helpful for everyone.
Thank you. Dr. Patel, do you have any advice or special advice for applicants?
So I agree, regardless if you're an IMG or a DO or an MD candidate, you have to try to present the best possible application to a program director or through ARS that you can to convey your fit for IR. Your challenge is no different in that regard. You may feel like you're at disadvantage because you're not a U.S. medical graduate, because we've seen the stats on the match numbers over the last couple of years. But program directors do look at all things, and it just means it might be a slightly different path for you. I don't know that it's any different for DO candidates personally. And then for couples matching, we actually did match someone who went through couples match into our IR residency. I do think that it's important to convey that you're doing that. And if in fact what your spouse is going into or your significant other is going into, and not that we can guarantee an opportunity for that other individual, it's always helpful to try to inquire on their behalf, particularly if you're strongly considered by the program. You know, if the IR applicant is strongly considered by me, then I would have no problem trying to reach out to the other program that couples matching with, and see if we can't at least let them know that we have a strong candidate on our behalf, and see how they view that. The last question is, what's the most important piece of advice for aspiring interventional radiologists? I get back to what I kind of said earlier. If you really want to do interventional radiology, this is really where you find your passion, whether it was coming into medical school or sometime in your preclinical years through an IR interest group, or you came across it by chance in your clerkships, then pursue it to the best that you can. And some of you will have the opportunity to do leadership work because you came across it earlier. Some of you will learn about it much later in medical school because of the path that your medical school provides you, and it doesn't allow you to see IR sooner than that. So maybe that means going through DR because you haven't established a track record or involvement or leadership in IR. Be prepared to apply to both, and understand then that the next hurdle is proving that during your DR 3 years of training that IR is really the right fit for you, and you'll have ample opportunity to be involved in RFS or other things where you can show true involvement, meaningful involvement at a local or national level. And then when you apply, say, to the independent residency at that point, or your local ESIR, you no longer are new to the game, so to speak, and didn't just learn about this great specialty at the end of my M3 year, and now you don't feel prepared to apply competitively to an IR integrated residency. But you might be competitive to a DR residency. I think you just have to continue to follow it. There's just a different path for each of you, and even those who are well qualified may have to go through the DR route, and there's nothing wrong with that.
Mm-hmm. Yeah, I'm looking forward to the upcoming webinar, I guess, for the independent match. Dr. Walker, do you have any pieces of advice, either special pieces of advice or overall for candidates applying for IR residency?
Yeah, I would just echo some of what's already been said. I look at all the applications. If there's a highly qualified international medical graduate, I'm going to look at that with a great degree of interest. We've certainly interviewed international medical graduates. There have been ones who have successfully placed, and that turns out that they are very competitive, and they're looked at as, an addition of diversity to training. I look at DO candidates just like I look at MD candidates. I think the couples matching thing really does typically work better, as Aaron said, in cities that have multiple institutions, such as in Los Angeles or in Boston or in Chicago or in New York. And I think that's just looking at the numbers. If you have the unique situation of couples matching who both want to go into IR, maybe that's a little bit problematic because these do tend to be small residencies. And so that would even be another sort of arrangement where you might look at multiple programs within the same city, including DR programs that would give the ESIR pathway. And I'll just circle back to kind of what I've said multiple times this evening, is that if you settle into the realization that IR really is what's calling to you for a medical specialty, I think aligning yourself as early on as possible with a really good mentor who will kind of help guide you through all of this, help you figure out ways to strengthen your application, even help you figure out things such as constructing a rank list and how to make yourself as competitive possible in that regard, would be things that might bring you the desired result if you just have a little bit of guidance.
I think that's a great note to end on. You've all served as mentors for us attending the panel, and we're really grateful for your taking the time to speak with us. With that, I'd like to transition to the last part of the webinar. I appreciate the patience of both the panelists and the students viewing the webinar. So the next part's questions and answers from the audience. So you can see in your GoToWebinar panel, there's a tab that says questions. And so in that panel, you can type in any questions you have for our panelists. We'll just take a few before we wrap up for the night.
Yeah. In the interest of time, we try to do our best to filter out questions that has already been addressed in the discussion. So we apologize to the audience if we did not get to your specific questions. So we have two questions submitted by the audience. The first question is, for students who have publication under revision or other work in progress, should these be listed on ERAS? If so, what is the best way to approach these on their application? And this is open to any of the panelists, so feel free to jump in.
So I'm sorry, when the question was if you have a submission that has not yet been accepted but is under consideration?
Yes, should this be listed on the ERAS application? And if so, what is the best way to approach this, to list them on the ERAS?
Probably a lot of it depends upon kind of the individual. And by that, I mean, if there's someone who has a number of publications and they're a first author, or a number of publications, even they're a second author, and a number of posters and abstracts and that sort of thing that have been published, that it might not even be necessary to list one. Like Dr. Marx said, if there's no scholarly activity, I think a blank space is probably a lot worse than listing something that has been submitted and is under consideration. In that case, I would just very clearly mark, what the name of the manuscript is, submission to JBIR or something such as that, and that, it's in the process of submission. I also think that, again, it depends upon the type of publication. The other things that we'll sometimes see is medical students who have done kind of basic science type stuff through research projects or whatever, but maybe they have done something that's IR related, but it's been submitted and it hasn't yet been accepted for publication or sent back for revisions, that sort of thing. I think I would like to see that, that there is someone that's working on an interventional oncology project or a PAD project or something like that, so that so you're actually showing that you have put the time to research and you have an IR interest. And so I would just mark it as, submitted or under revision or something such as that.
Thank you for that insight, Dr. Walker. Dr. Patel and Dr. Fischman, do you have anything to add?
I agree. I think you should put things on that would be of interest to us as we talk to you and as we read through your application. And so even though it's not a submitted or an accepted project, I think a lot of these things are important for us to understand your interest, and there's no reason why you can't. I don't know exactly how that works in ERS in terms of how it's listed, but there's no reason why you can't. I've definitely seen people put those types of things in the application. They do come through.
Thank you.
Yeah, I agree. I don't know about how that process works for ERS, but I've certainly seen people denote work in progress or in publication, or at least an opportunity to at least list it on ERS. So I don't think there's anything wrong with that.
Thank you. So the final question is, in reviewing the application, do you factor into which medical school the applicant is applying from, since different medical school may have different grading criteria?
I'll start. I don't think the school itself influences me as to how I judge them. As far as grading criteria, some are pass-fail, some have honors high pass. At the end of the day, I'm looking at trends, as we mentioned earlier, in the preclinical years and actual, the dean's letter and actually clerkship scores, whether that's still, again, a pass-fail strategy at that school. I also look at the comments and particularly at the core clerkship areas. And then ultimately the letters of recommendation ends up being a totality of the application, not just how grades themselves are deemed at a particular institution. And there's big schools, there's small schools. We have great applicants coming from all kinds of places, so you can't really limit it to that kind of screening methodology.
I agree with Parag on that one. It's all those things are important. I don't think I have anything else to add, actually. Maybe Greg does.
I'm the same, Aaron, and I agree with Parag. I mean, yeah, all different schools have different grading criteria, and sometimes just trying to understand those becomes a little bit difficult. And it is kind of the totality of everything. Obviously, the dean's letter is a nice sort of summary of how a medical student has performed relative to his peers, relative to the class, and it's supposed to kind of try to stratify that a little bit. And I think that's really very, very useful. But you have that, and then you have really, really strong letters of recommendation, perhaps a clerkship where someone has performed very, very well. So I think it's a composite of everything once you begin to look at the application.
Thank you for the insight. So I think that's all the questions we have from the audience.
So with that, I appreciate everybody staying a few minutes later. What we really want to say is thank you very much to our panelists. We want to thank Dr. Fischman, Dr. Marx, Dr. Patel, and Dr. Walker for really taking the time out of their busy schedules to speak with us and share some of their insight and their perspective on this process where, again, we either have questions and we're just not sure what the answer is, or we've heard a couple different things and want to get a better idea. We also want to give special thanks to Justin Guan, Charles Hyman, and Lauren Park for their help with this webinar. And then if you weren't able to see all of this webinar, we'll be posting this meeting with the panel's permission onto the YouTube channel for the RFS. And we want to thank you very much for joining us. If you do have follow-up questions regarding the panel or suggestions for future panels, please feel free to email us at sir.msc.education@gmail.com. Thank you all very much.
Thank you, everyone.
Thank you.
Thanks, guys.
Thank you, everyone.
Thanks so much.
Justin, if you're still there, is there anything special we need to do for the recording? All right.
So I don't know what's the best way for us to do this. Do we just sign off?
I think we just sign off and then the recording will be saved. I believe that's what happened last time. I think it all gets uploaded automatically. So with that, I'll log off. Thank you all very much. I see Dr. Patel still here. Thank you very much, Dr. Patel.
Thank you, everyone. Have a good night.
Good night.